can't
also
remember this. I think we're kind of warming up to single parent.
I know it's something about it.
No, I don't know if I'd go that far. I think they had a resolution. I forget the most recent one. I think overall they've shifted. They've shifted into somewhat more of a girlish direction.
I don't feel like getting this serious. So Rona's going to introduce Jacobin and then he's going to introduce you.
Are we ready to be in then?
Yeah, we're ready.
So Adam,
Yes.
you heard Katie matched the best general.
No, I did not know that.
Yeah, and apparently for first choice.
Congratulations.
I would be the last to know. But I'm very happy because she'll be nearby.
Yeah. What is she? She's doing medicine.
Medicine. She's matched in primary care medicine. Even though she's not sure she wants to do primary care, she thinks she'd be happier there.
Okay, good for her.
Yeah.
That was
She
the
wants
first
to do
choice.
ID. Yeah, it was apparently.
Is this on?
Yeah,
Hello?
it was.
Wonderful.
That was her first choice.
Can you hear me?
And but she was telling you on her first choice because she didn't want to. She got her second choice.
She wanted to have the,
We heard you were going to San Francisco or whatever it was.
I understand.
Hello?
Yeah, so it turned out.
Oh, and
Is this on? Can anyone hear me?
Until she
Hello? How's things? Up until like 3 minutes ago, I didn't know I would be doing this, but Bhaskar decided, as I'm a token Irish member of Jacobin staff, that today is a day for me to open this. And thank you all very much for coming. We really appreciate it. This is obviously an important issue, most particularly for you guys over here in the States, with the struggles that are coming up ahead of you on healthcare. Before I start by opening up to the panel, I would say that we have obviously some copies of Jacobin over there, and also some material on support for the New York Healthcare Act. Is that right? Okay, I'm trying to get that right. I suppose this is a kind of tribute in my own small way to healthcare, to say that this is probably the most sober I've been at 7:30 on a Patrick's Day. So I will be able to get through. Just thanking very much everyone who contributed, first of all, to this issue on healthcare, which I think is really important. I know you're going to hear more now from Adam and Natalie and Steffi about the articles in the issue. So before I go any further down the line of talking about healthcare, I wanted to read something just very small, which I often do on Paddy's Day, from James Connolly. I think it's an important and relevant quote. You know, these days, national days very often get debates taken away from any kind of context they may originally have had. And Connolly had a favourite way of talking about that in reference to St. Patrick's Day, where he would talk about the kind of, skin-deep national pride, even within anti-colonial struggles, which often had very little to say about social issues and the people who actually made up the nation. His quote, most famous one, was, "Ireland without her people is nothing to me, and the man who is bubbling over with love and enthusiasm for Ireland and can yet pass unmoved through our streets and witness all the wrong and the suffering, the shame and the degradation wrought upon the people of Ireland, wrought upon Irish men and Irish women, by Irish men and Irish women, without burning to end it, is in my opinion a fraud and a liar in his heart, no matter how much he loves that combination of chemical elements which he's pleased to call Ireland." So with that, I will hand over to the panel and a discussion of healthcare over here, and hopefully afterwards you will all do quite a lot of damage for one night only to your healthcare.
Thank you, Ronan. So welcome everyone to the issue launch for issue 28, The Health of Nations. And we're so lucky tonight to have this great lineup of speakers who I'm going to introduce in just a minute. But I want to say first also that this is a very timely issue. While healthcare has long been a topic of national debate in this country, we are experiencing a moment where single payer has reemerged as a viable option. You can see, for example, the support that's been growing for Bernie Sanders' Medicare for All bill, as well as public polls showing a shift in opinion towards support for a single payer system. And I also think it's worth mentioning that there's been struggles around healthcare that are showing that it's a flashpoint for workers. I think I'd be remiss right now to not mention the West Virginia public school teacher strike that was recently victorious. Yeah. Which, while was also about wages, was also importantly largely about healthcare benefits and protecting those. So this is an issue we should see as a flashpoint for workers in this country. And that's not surprising because, as we're going to get into tonight, we have in this country an extraordinarily irrational and costly and ineffective healthcare system that every day fails to ensure quality, affordable healthcare for millions of people. And the for-profit markets in healthcare make this so. So we're going to draw out some of why profit incentives distort priorities in both the provision of healthcare as well as health research, and why we need a radically different system that puts human needs first. So with that, some introductions. I'm Laura Bartkowiak. I'll be moderating tonight. And with us we have Dr. Adam Gaffney, who co-edited this issue and is an instructor in medicine at Harvard Medical School and a pulmonary and critical care doctor at Cambridge Health Alliance. For the new issue, he wrote, "Do We Need Pfizer?" detailing the ways in which drug research and development are shaped by the profit motive. Next, we have Natalie Schur, who's a TV producer and writer whose work has appeared in The Atlantic, Slate, Pacific Standard, and elsewhere. And she wrote Model Consumers for this issue about the failures of Obamacare. And then we have Dr. Steffi Woolhandler, who's co-founder of Physicians for a National Health Program and a primary care doctor in Cambridge. For this issue, she co-authored How Single Payer Could Fail. So a bit about how it's going to work tonight. I'm going to pose some questions to the speakers, and then we'll have some discussion up here. Then, because it's a little bit tricky to live stream audience Q&A, we're going to say goodbye to the people watching at home, and then we're going to open it up for some audience questions, and then we'll bring it back to the speakers to respond and wrap up. So to start, for Steffi, you helped found Physicians for a National Health Program about 30 years ago now. So it must be incredibly gratifying to see thousands of people pouring into organizing and movements for healthcare justice. But it's clear to millions of people we don't want this system. However, it's not always clear what we're fighting for exactly. I found your piece in the Jacobin issue so helpful in expanding understanding for what we need to do beyond just health insurance. Can you start us off by describing your dream healthcare system, a single-payer system, one that puts human need above profit seeking?
Well, the wonderful thing about healthcare is that we have several pretty good models out there in other countries that do a good job of covering everybody in a single public system that has real equality between rich and poor. For instance, Canada's run a single-payer system for decades that has complete coverage for hospital and physician care without any co-payments or deductibles. They still have some issues about pharmacare, which hopefully they'll fix. There's also systems like Scotland, where absolutely everything is free in the Scottish health system. Even the parking is free, because why should you pay for parking if you're sick? And the Scottish say, we don't view the patients as consumers, we view them as our owners. So, there's other developed capitalist nations, if you will, that do have healthcare systems that do a much better job of providing healthcare and meeting human needs. In terms of a dream, the issues around international health have been less well developed, and certainly we would want to have a system, a single-payer system like that in Canada and Scotland that work very well at a national level, but we'd have to do some additional thinking about how you use your healthcare system to achieve global health goals.
Thank you. In your article, you also talk about some of the ways in which single payer could be undermined by half measures like a public option, which I think some people do see as a step forward. Could you speak a little bit about why that would be a path that we shouldn't pursue, what single payer would look like?
Well, first of all, let's be entirely clear. Public option came up as a way to block discussion around single payer. Having said that, the small form of public option just is that people who wanted to buy insurance could buy into Medicare. Would not be a terrible thing because that would mean that people who are ready to buy insurance would have another option. But it's not going to solve the healthcare problem because most people don't have the money to buy into Medicare. And Medicare would turn into essentially a high-risk pool where all the really sick people who the private health insurance industry don't want would end up in the Medicare program, which tends to actually raise prices for everyone. So a public option in the small sense is actually a very narrow idea that doesn't do much to get us to universal health care and actually would tend to raise costs. There's other ideas, maybe we'll get into them a little bit later in terms of the new Medicare Extra proposals that are somewhat like a public option, except that everybody is automatically enrolled in a Medicare-like program if they don't purchase private insurance. That, too, was really offered to try to block single-payer work and is not actually economically feasible to do in that way.
I think that is a good segue into a question for Natalie. I want to talk a little bit about where we're at. So we're some years into the implementation of the Affordable Care Act, or Obamacare, which for many, I mean, certainly for me at the time it passed felt like a victory. However, it's proven pretty inadequate, despite some positive aspects of it, like banning insurance companies from practices such as lifetime caps on coverage or discrimination for pre-existing conditions. However, your piece was so sharp in laying out why the ACA hasn't been able to fulfill the promise of universal health care. Can you say something about that and how single payer could approach the issue differently?
Sure. I think that it is important to note that the Affordable Care Act was undeniably an improvement over the status quo that came before it. But it failed to produce a universal system because it didn't actually provide the infrastructure to do that. I think that even before you consider the economics of a lot of the failures of the ACA, when you just look at the fact that it built off of an infrastructure with so many different forms of insurance, so many different forms of coverage, and how many gaps there are to fall into that, even if you presume that everyone can afford it. Things like if you move to a new job, you might have a 60-day gap. If you get a divorce, you might lose coverage. If you cancel your debit card and didn't remember to change your payment information in the website that you get your insurance through, that could result in a loss of coverage. And so there are so many gaps that exist that even in a perfect situation where everyone can afford coverage, we still wouldn't have a universal system because it basically places the onus on individuals to be hyper-vigilant to make sure that they maintain coverage at all times. Of course, when you do add in the fact that we know that we live in an incredibly unequal society, this problem is exacerbated very seriously. The individual mandate, which I'm sure you guys have heard discussion about, the idea that we can get to universal coverage by whacking everyone with a stick and forcing everyone to pay a large fine if they don't get coverage. Certainly there are some rich, healthy people who are lackadaisical and cocky and think that they'll never die and don't buy anything because they don't want to, but that's a very, very small population. The fact is that a lot of people can't afford coverage or are very, very cash-strapped and realize that if they could afford to pay for a premium each month, then they might not be able to afford the deductible once they have the coverage. And so if you look at all of these things, the ACA basically imposed a series of methods to basically convince people to be better at interacting with the insurance system, which I don't think can fairly be called a universal system or a structure that would even get us toward that. So it's fairly clear that the ACA would never result in a universal system, that we know that, best case scenario, the methods that they built to build a universal system results in 20-something uninsured people and many more who are underinsured, who have plans that they can't actually afford to use because there's such heavy cost sharing. I think that that's a place to start, to realize that, not only has the ACA failed or, is not going to get us to a universal system because that's not what it was designed to be in the first place.
Great. When you mentioned cost sharing, I know you've also written for Jacobin about copays and cost sharing. I wonder if you could say a bit about that too and why that's in tension with a universal system, because I know that an earlier draft of Sanders' legislation did have some language in it around copayments, and the final version that was removed, I think, from pressure from healthcare advocates. But can you say a little bit more about that? Why no deductibles, no copayments at the cost, at the point of care? Why this is in opposition or in tension with a single-payer system that we're looking for?
Sure. So when I wrote in the piece, and like I was just saying, I think that the underlying logic of a lot of these methods in the Affordable Care Act, and certainly built into the philosophy of cost sharing, is the idea that we can control healthcare costs by building all of these micro incentives to convince people to be really good at using healthcare and to be really like intelligent, savvy consumers, and that's going to be the method by which we convince millions and millions of people to use this system very well, which, I mean, of course, is a completely ridiculous way of looking at a national healthcare system. And it's also, I mean, it's a lot more insidious than that. Cost sharing, if it does reduce use of care, which is, I mean, debatable in the first place, it does so by basically scraping off the people who are too poor to afford the copay. For a lot of people, a copay isn't a problem, and that's why we don't see an epidemic of super wealthy people who go to the doctor as soon as they have a sniffle. It's a ridiculous notion that anyone would do that, and we know that people don't. But the people who are cash-strapped are the ones who are going to be forced to think twice, who are going to be forced to consider their budget lines about whether they want to buy baby wipes or diapers or pay for a copay this month. That those are decisions that don't affect everybody equally. And, you know, the idea that copays, things like deductibles, things like coinsurance, convince people to reconsider their use of healthcare, and that those decisions are they burden people unequally. And so to have a truly equitable healthcare system that's equally available to everybody, it's very important to handle the finances of it somewhere that's not the actual doctor's office. Care that's free from the point of service. When someone actually goes to care, that they are able to get it without a financial barrier of any kind, is an incredibly important thing to do when building a universal system.
So I want to move to Adam. Congratulations on the new issue. Thanks for helping put it together. I think it gives so many great tools for understanding what we're up against when fighting for universal health care. For example, the for-profit pharmaceutical industry, you wrote about why we need to take them on and think about a public program. Can you talk a little bit about what that program for drug research would look like and how it would improve on the current way in which research and development in pharmaceuticals is conducted?
Sure, and thank you. And thank you, everyone, for being here. This is such an honor to be speaking to all of you. So I wrote about the pharmaceutical industry and how it needs to be more fundamentally reformed. Now, we might say, well, isn't creating a single-payer system enough right now? That is a big, project, and we're not going to get there overnight, and it's taking on very powerful industries, and wouldn't that be enough to achieve single payer and deal with the pharmaceutical problems later? And the answer is no, that we need to do both. And why is that, and what are the problems, what are the big problems in our pharmaceutical system right now? Well, I think the first thing that would come to anyone's mind and would be prices. I mean, we know this. We know there's been scandal after scandal. The Martin Shkreli business, where he jacked up the price of a drug used by patients predominantly with AIDS through the roof overnight just because he cornered the market. The EpiPen fiasco, where they again jacked the price up because they could. Every day you hear a new sort of horror story of a drug price being, jacked up to the roof to the extent that people who need it can't afford to actually obtain it. In the article, I start with the story of insulin. So, again, insulin was initially developed in the 1920s. in Canada, by researchers who actually basically didn't really bother to even patent it until a couple of years later, and didn't envision actually getting rich off the patent. And now, almost 100 years later, you have drug companies taking sort of revised versions of insulin, jacking up the price through the roof to the extent that people can't afford it, and it's a disaster. So one answer to that. So the question is, what do we do about that problem? And it's a problem that I think many of us in this room face it personally, or know people who have been unable to obtain medications because of price. So a single-payer system could do a great deal as a first step. If you had a single-payer system, the government system would negotiate with pharmaceutical companies to bring drug prices down. That happens in other nations, and we could probably expect that you could reduce drug prices, if we're going to use international comparators, by about 50%. That would be wonderful, and we need to do that. But that wouldn't be enough. And why is that? And it gets back to the way you phrased the question, which is that the for-profit motive and the role of the pharmaceutical industry has been to corrupt the whole process of drug development, promotion, sales, research and development. And if we're going to have a better pharmaceutical system, we're going to need to go beyond simply reducing prices and keeping the same infrastructure intact. So first off, why are drugs so expensive? So drugs are not actually expensive to make. They're pretty cheap to make. Generic drugs can be made very cheaply in the vast majority of situations. So they're expensive because of patents. And so we all know that. That's pretty common sense. And so the question is that the only way to do this? And the answer is no, right? This is one way we've chosen to develop drugs, by giving patents to drug companies that allow them to price drugs at whatever they want, which often can be, in the case of like the hepatitis C drugs, tens of thousands of dollars a year. And that has real consequences. There was just some research about how the vast majority of prisoners with hepatitis C never get treatment, right? So people are basically being forced to succumb to curable infectious diseases because we think that the pharmaceutical industry's bottom line is more important than human beings. But to change that, we need to go beyond bringing the drug price down from $50,000 to $25,000. We need to start thinking about drugs as a public good. As I said, the development of insulin was done by researchers who weren't really intending to get rich and weren't intending to get rich off patents. There's the famous line from Jonas Salk about when he's asked about, who owns the patent for the polio vaccine, and he says something like, well, I'd say the people own the patent. So why can't we take that as a model? And there's no reason we couldn't. The vast majority, so much of drug development is already being paid through the public purse, through the National Institutes of Health. All of the basic infrastructure to figure out how molecules work, how cells work, how diseases work, is already being funded publicly. Why not take that one step further? Develop great public drug development organizations that develop drugs throughout the whole process to the point of having a new molecule that is owned by the public and can be produced at the cost of production. That sort of drug could then be made available throughout the world at the cost of production. And that is what, one element of a more just drug system. Is that going to happen overnight? No, but you could do that bit by bit and grow such a program until an increasing proportion of all of our drugs are owned by the public and are developed by people who are being paid for their labor and for their work, but have no expectations of becoming billionaires because they happen to patent the right drug at the right time. That being said, even that is not enough. And some, if you look at every kind of step in the development of a drug, there's so many perverse incentives. The way clinical trials are run, the fact that they're being run by companies who have a financial incentive in the outcome. The fact that tens of billions of dollars a year are being spent by pharmaceutical companies to promote their drugs, to sell them, to push them on doctors and patients. It's a distorting effect that is not only a waste of money, but it results in drugs that are not necessary for certain people being sold or being prescribed because of commercial incentives. So I think when we're thinking about the pharmaceutical reform, single payer is absolutely necessary. And we need that to bring down drug prices, negotiate down drug prices, and also create a universal right to medications without, as to go back to what Natalie was saying, copays. There's no reason to have copays for drugs. Nobody takes drugs. Nobody takes prescription drugs because they want to. They take them because they have to. If anything, people avoid taking drugs that they even need to. Because who wants to be on medications? You don't need a disincentive of a copay, much less for a cancer drug, right? I mean, what is the possible incentive of creating a high copay or deductible for chemotherapy? Are you trying? The only effective result of that is to punish people with cancer. There's no other. There's no moral hazard of chemotherapy. So we need a single-payer system to accomplish those goals and to create a right to medications. But we need to think more broadly about a left strategy towards reforming the pharmaceutical system all the way. And that doesn't need to be done overnight, and it probably won't be. But it must be a key goal of the left in this country and globally.
Thank you. So I think that brings me to the next question, which, if we need to take on things like the pharmaceutical industry and single payer as a step towards that, if I'm understanding you, how are we going to get there? In your introduction to this issue, Adam, I was struck by how you laid it out as if historians would be chronicling the success of a Medicare for All movement, and I liked that, especially given all of the ways in which the issue takes on all of the obstacles that we're likely to confront, or in which single payer could be undermined in practice through half measures. So given that healthcare is, at this point, 1/6 of GDP, and we saw, as with the attempt in the 1990s under Clinton for a national health program that failed, we should expect a lot of pushback from the insurance companies and the pharmaceutical industry and anyone else with a financial stake in the status quo. So given all of that, how do we set ourselves up in a movement for single payer, for healthcare justice, to weather that onslaught? What are we going to do electorally in terms of organization building? And what's the part that workers will play in your eyes? Will we need strikes? Basically, what's the road from here to Medicare for all? And I think maybe we can go back the other way again, starting with Steffi.
Well, I think the road to Medicare for all involves mobilization, and people need to be mobilizing where they are. So people who work within the labor movement certainly should be thinking about mobilizing within the labor movement. I work in healthcare and work primarily around organizing doctors and other healthcare workers. But it's a movement. It has to be at all levels of society. That's actually how national health programs were achieved in a lot of Europe. Often those countries had a labor party, which we don't really have. But it took a political movement. There was no trick to it. The insurance industry is not just opponent of single payer. They're in a life or death struggle about this. And in fact, there was a head of the group that's now called AHIP, the American Health Insurance Plans. It had a different name at the time. It's a big lobbying group for the largest insurance companies. And Mr. Schramm was asked once what the insurance industry thought about single payer, and he said, we're completely and totally opposed. It's a life or death struggle for us. So a true single payer does mean the end of the private health insurance industry. I think it doesn't mean the end of the pharmaceutical industry. It certainly constrains their prices, so we've got a big opponent there as well.
Natalie?
I think that it's very important to harbor zero illusions about how strongly they will fight against this. That's not only the insurance industry, that's, as Adam mentioned, the pharmaceutical industry. Any member of the for-profit medical industry is going to absolutely fight against this tooth and nail. We already have historical examples of that. The most viable moment in American history when a single-payer system could have come to fruition is probably in the late 1940s during the Truman administration. The healthcare industry, including the AMA, really mobilized against it at that moment. And so we should have no naivete about the fight that we're going to be up against. I think that there is room for optimism, though, in the fact that If you are going to have massively well-funded opponents fighting against you politically, it helps that they are gruesome, detested companies. That the insurance company, the insurance sector is not a popular one. The vast majority of people, by definition, any interaction you have with your insurance company is horrible and demoralizing and boring, and you're on the phone all day, practically screaming with steam coming out of your ears like you're a cartoon character. And so I think that these are not difficult villains to conjure up in people's minds. And I think that we have to keep that in mind. I think that in the past, a lot of healthcare reform chatter has been very wonky, has been, focused on how complicated healthcare is, and, to some degree, depending on what aspect of it you're talking about, that's obviously true. But it's also true that these are companies whose their bottom line, their entire reason for existing is to profit off of the healthcare system and keep people from accessing healthcare if they can't pay for it, and that should be villainized, and that should be something that we rattle cages about. And I think that, very much maintaining that posture during activism, villainizing these companies whenever we can, is going to be important. And I don't think it's going to be a hard sell. I think that that's what we have on our side.
I agree with Natalie. But also, I have a couple other points. I think that one thing I'd say in response to this, from sort of a policy perspective, is that the stakes of this are very high, and the opposition is very powerful. And that actually means that the way we design this system as a proposal really matters. We need to have a proposal that makes most people's lives better, if not nearly all, right? And that's why the specific design of the Medicare for All system we're talking about really matters. So, for instance, to bring it back to the copay side of things for a second, if you propose a Medicare for All system that covers everybody, but it has copays and deductibles, well, guess what? That's actually not going to improve everybody's lives, because there's going to be some people with good insurance, right, or reasonably good insurance now, whose lives could get worse. What makes Medicare for All so feasible, the kind of Medicare for All that we're talking about, what makes it feasible and doable despite the enormous power and war chests of the opposition, is that it could in fact improve the lives of the vast majority of people. So people with Medicare currently, would they benefit from Medicare for All? You might say don't they already have Medicare? Well, yes, because when we say Medicare for All, we're talking about expanded and improved Medicare for all. People with Medicare currently, actually, it's not always a great insurance system for them. They still have copays, they still have deductibles, it doesn't cover dental care, and it doesn't cover things like long-term care. Well, if we create an expanded Medicare for All program, an improved Medicare for All program that does cover those things and gets rid of their copays and deductibles, well, guess what? Now people currently with Medicare have a real stake in this debate, right? For people who are uninsured currently, well, that's an easy sell. You're giving them insurance that would cover comprehensive health care that they otherwise would not have. How about for people who are currently insured through their job? Well, as Natalie said, people don't have a very high a great opinion of their plans most typically. And also, the trends in the healthcare insurance ecosystem are towards worse plans. Deductibles and the thousands of dollars, copays. And let's not forget, every time, as you said, you get divorced or you lose your job, you have to always worry about what comes next. How am I going to be insured? So the reason why I do think that Medicare for All is something that we can win in spite of the opposition is because it's something that, for the vast majority of people, it really gives them something to fight for. That being said, yes, the opposition is going to be enormous. If we think we've faced opposition now, kind of supporting single payer, let's see what happens once it actually is something that is around the corner, once it is legislation at the national level that could be passed. At that point, the pharmaceutical industry and the health insurance industry are going to open their war chests wide and pour whatever amount of money they need to try to defeat us. So we shouldn't have any illusions about how difficult that fight is going to be. But let's also look at all of the progress we've made in the last few years. And I think that the Sanders campaign really helped catapult single payer forward, no doubt about it. The ground was laid by years or decades of activism for sure, but that helped push things forward. Last year we saw that very radical single-payer bills in both the House and the Senate, gained unprecedented support. The bill in the House, H.R. 676 for expanded Medicare for all, suddenly gained a majority of representatives who were in support of it as co-sponsors. And we know that Sanders' bill acquired 16 co-sponsors. His previous bills had 0. Now, why did that happen? Is it that suddenly, politicians saw the light and realized this was a good idea? Probably not, for the most part. They saw which way the wind was blowing. The grassroots, the activism, the changing discourse, they saw that and they responded. So that's a hopeful sign where we've come in the last couple of years. But yes, it's a huge fight ahead, and it's going to require all of us working, as Steffi said, where we are, whether the labor movement, whether DSA, other activist groups, other healthcare organizations, or whatever it is, all the huge number of organizations that are working on this sort of thing and working together in coalitions.
So you sort of got to a follow-up question I want to ask in that. So I hope everyone in this room is convinced that single payer is the route to go. Of these 100 or so people in here, what would you say they leave this room and do? What do you think they should get involved in? What's the next steps for someone who says, okay, I'm convinced that this is the correct path to take. What should I do next?
Well, I certainly think people want to work through organizations if they can. There's plenty of organizations here in New York City that work on single payer. I think people want to be talking to other people as individuals. People want to be writing letters to the editor. It's often very effective. Particularly community newspapers are often looking for material. I think people need to be educating other people about what a single payer is, because so many Americans are kind of discouraged and they feel like the Affordable Care Act just didn't work, and now, what are we going to do? How can we possibly make this complicated system work? Certainly people need to be correcting a lot of the misinformation that's being put out, currently a lot by the mainstream of the Democratic Party, unfortunately, has been putting out a lot of misinformation about how other countries might make single-payer work. They can make economics work in Canada or in Western Europe or in Scotland, but somehow or other, the United States, we simply can't make it work. So we need to be working in all sorts of different ways and different levels to really try to get the single-payer message across.
I think that's what I would say as well. What Laura said about working where you are. Each of you have some intersection in your life with a great way to get this message out. If you are part of a labor union, not all labor unions have officially endorsed single-payer health care, or some that aren't necessarily working toward it. You can work within your union to try to find ways to spread this message, to make that part of a campaign message for any campaigns you might be working on. I personally am very active in my DSA chapter, Democratic Socialists, in Los Angeles. Most DSA chapters, we voted for national priorities at the large convention over the summer in Chicago that Medicare for All, single-payer health care, is the organization's top priority until we next meet. And so if you do have a DSA chapter near you, that can be a great way to mobilize. You can join a canvas. You can join some of their educational programs. If you are, part of any different sort of organization, any different workplace, I think that there are people that this can affect in a lot of different ways. And I think that finding intersections, finding, different ways that single payer can affect different populations depending on who they are, where they live, the realities of their life and how it intersects with the healthcare system. There are, different ways to tailor messages and different ways to speak to different people depending on their values and their needs. And I think that thinking hard about those things is a great way to figure out how to communicate with new people and get involved with them for this fight.
I don't have too much to add to that. I think the one thing I'd say is that what I do think is really great about single-payer activism is the extent to which it's something that affects almost everybody in a different way. I think almost everybody has had interactions with the healthcare system that have left them unable to get the care they need, in debt, hassled, frustrated. And so there really is a broad audience and a very receptive audience for these messages. I would agree with everything that you two said. There is no one organization that's going to make this happen. This is going to be a coalition of organizations, of unions, of nonprofits working together. I don't think anybody knows the road to single payer. What we need is a massive grassroots social movement that is based in the working class and that has the tools and the language necessary to counter what's coming from the ruling classes. And I think that with that we can win it, but going to be a difficult fight for sure.
Great. I think with that, I want to move into the audience section, audience Q&A section of this. So that means goodbye to the live stream. Thank you everyone who was watching at home for joining us. And